From 2009, the Fetal Medicine Foundation group described a new algorithm that combines not just maternal history, but other factors that we know that they are abnormal in preeclampsia, such as blood pressure using a specific technique, the mean arterial blood pressure technique, measuring the blood flow in the uterine artery Doppler by ultrasound between 11 to 13 weeks, and also the measurement of two biomarkers, that's PAP-A and PLGF. Putting all these markers combined in an algorithm, you can predict around 75 to 80% of the patients that you have high risk for preterm preeclampsia. When you compare the detection rate of this new algorithm with the conventional guidelines, the performance of this new algorithm is much, much better. To answer these big questions, if the screening is possible to be performed in different countries, and also to check if aspirin was really effective to prevent preeclampsia, a large study was done by the Fetal Medicine Foundation group. This study was published very few months ago. That's called the ASPRE trial. This study showed two very important things. One, that the screening works in terms of performance quite well in different countries from Europe, with literally hundreds of different doctors performing the screening. And for the truly high-risk group identified for this screening, placebo or aspirin was prescribed. After this large trial, it's very, very well proved that the screening works to identify a truly high-risk group. And if I'm prescribing aspirin for this group, I can have a 62% prevention of preterm preeclampsia. In our setting, we introduced this screening a few years ago. At this point in time, we screened over 30,000 patients with preeclampsia. In the Australian setting, the screening is working quite well. And nowadays, we are prescribing or suggesting for these patients to have low-dose aspirin between 12 to 36 weeks, and you are expecting to prevent a good number of patients with preterm preeclampsia. I think that my message is a clinical implementation. We have enough evidence at this point in time for this test to be started in clinical practice, and different countries, they have to check if this test is cost effective. And it's not difficult to imagine that we can save money offering this kind of test, because you're having less maternal complications, less perinatal complications, in consequence, less necessity of neonatal intensive care. And absolutely, you are going to save some maternal lives and some babies' lives using this new approach.